part of the brain which is important in terms of motor motivation is basal ganglia. Now the function, if you compare the function of the cerebellum to the basal ganglia, the cerebellum is mainly a comparator, where it is comparing the intended movement with the actual status of the joints, and then sending corrective signals back to the cortex so that the corrections can be done while you are performing a movement. The function of the basal ganglia, on the other hand, is like a switch. So what it is doing is that when you want to start a movement, the switch is turned on, and when you want to terminate the movement, the switch is turned off. So it's like a switch. It's going to, when you intend to start the movement, the inhibition from the basal ganglia to the thalamus and to the cortex is going to go down, so that you can start the movement. And when you want to terminate the movement, the switch will be turned off, so that the inhibitory discharge from the basal ganglia to the thalamus and to the cortex will start appearing. So this is like you imagine basal ganglia as a switch for turning on and terminating the movement. Okay? Okay, so today we are going to talk about the function of basal ganglia in detail. We are going to describe the anatomical location of the basal nuclei. Well, we will start to relate the neuronal circuitry within the basal ganglia with diseases like Parkinsonism and Huntington's chorea. So we will talk in detail about the direct and the indirect loops within the basal ganglia and how they are related with diseases like Parkinsonism and Huntington's chorea. So there are four large subcortical nuclei which are called the basal ganglia. So they are present in the base of the cerebrum. These are four large subcortical nuclei. Although they are, the collection of cell bodies in the base of the cerebrum, so they should have been, the better name for basal ganglia would have been the basal nuclei, because we know that ganglia are usually out of the central nervous system. But this is a misnomer which is being used, around the world. The basal ganglia are four large subcortical nuclei. They play a major role in the control of the voluntary movements. They receive inputs from the cerebral cortex, and they are going to send back the information through the thalamus to the prefrontal, premotor, and the primary motor cortices. The role of basal ganglia started to appear when we looked at the clinical presentation of patients in diseases like Parkinson's disease and Huntington's disease. And then when we performed a post-mortem brain tissue analysis of these patients, we found that there was degeneration of certain areas of the brain, which we now call as basal ganglia. So from these diseases, we found out that there are three characteristic types of motor disturbances which you would see with patients with basal ganglia. One is tremors, the other is involuntary movements, changes in muscle tone and posture, and poverty of movement. So these are the features of basal ganglia disease. So you don't see any spastic paralysis here. So this is quite different from what you see with the problems with the pyramidal system. So that's why we have divided, based on these clinical findings, we have believed that the basal ganglia is a part of the extrapyramidal system, distinct from the pyramidal system, which includes the corticospinal tract. Because if you have damage to the corticospinal tract, the pyramidal syndrome will happen, which means spasticity and paralysis. And in extrapyramidal syndrome, you have involuntary movement, rigidity, immobility without paralysis. So even in Parkinsonism, you would find immobility. You would ask the patient to move his hand, and his hand would move like this. So it's a jerky, rigid movement which is happening. But at the same time, it is not a paralysis. So, but if you take a patient with stroke and has a spastic paralysis, you ask him to move his hand, he cannot move his hand because it's paralyzed. So the most important thing which you need to differentiate is that in the extrapyramidal syndrome, you might have immobility, but there is no paralysis associated with it. Okay? So So there are four principal nuclei, as we said, in the basal ganglia: the striatum, the globus pallidus, the substantia nigra, and subthalamus. The striatum is called striatum because between caudate and the putamen there are striations of grey matter, and that gives you in a fresh brain sample a striated appearance. That's why it is called striatum. So striatum principally consists of caudate nucleus and putamen. Globus pallidus has two portions. The lateral portion is called globus pallidus externa. The internal portion is called globus pallidus interna. Substantia nigra, we know that it's present in the midbrain. These are dopaminergic containing neurons. Again, there are two parts of it. One is called substantia nigra compacta. The other is called the substantia nigra reticulata. And the fourth nucleus is the subthalamic nucleus, which lies between the thalamus and the midbrain. We can divide these nuclei into inputs and outputs. The major input to the basal ganglia is striatum. That means the caudate and the putamen are the ones which are going to receive the input. The major output is the globus pallidus interna and the substantia nigra reticulata. So substantia nigra reticulata and globus pallidus interna are the major outputs. So they are going to send outputs to the thalamus and from the thalamus to the cortex. So the major game plan is that whenever the cortex is going to excite the basal ganglia, so there is excitatory impulse from the cortex going to the basal ganglia, it is going to reach the striatum. So these are glutaminergic neurons which are going to excite the striatum, and as a result the striatum is going to inhibit the globus pallidus interna, and globus pallidus interna is at rest. When you are sitting at rest, is sending continuous inhibitory discharge to the thalamus and to the cortex. So this discharge will transiently stop, so you can start a movement, a voluntary movement. So your inhibitory discharge, which was continuous from the basal ganglia to the thalamus, would transiently stop in response to the stimulatory response to the basal ganglia, and as a result you can start a movement from the cortex. So at rest, why we don't have any involuntary movements? We are exposed to the environment at rest also. So your sensory receptors are being excited by the environment at rest also. But you don't have involuntary movements. The reason for that is that basal ganglia is continuously sending inhibitory discharge at rest to the thalamus, and that does not allow the cortex to get excited by the sensory stimulation. But when the cortex decides to have a movement, it is going to have an excitatory signal going to the basal ganglia, and in response to that, the basal ganglia will be inhibited transiently to send the inhibitory discharge to the thalamus and to the cortex, and as a result you can start a movement. And when you want to terminate the movement, again this inhibitory discharge will start. So it's like a switch on and off. So you have a precise movement. When you want to have a movement, your inhibitory discharge from basal ganglia will stop to the cortex transiently, and when you want to stop the movement, the inhibitory discharge will start again. Okay, so the major neurotransmitter for the basal ganglia is GABA, which is the inhibitory neurotransmitter within the basal ganglia. But you also have other set of neurons which are having certain different types of neurotransmitters. For example, the substantia nigra compacta is going to release dopamine, while the interstriatal neurons between the putamen and the caudate are going to release acetylcholine. So these neurotransmitters, these three neurotransmitters are important in the regulation of the function of the basal ganglia. That's why when you are going to learn about the drugs related with modifying the diseases related to the basal ganglia, you would be talking about drugs which will modulate acetylcholine response, drugs which are related with dopamine response, and drugs which are related with GABAergic responses. Okay, now we are going to look at some of the anatomy of the basal nuclei. So this is the sagittal section of the brain, and from the lateral to medial we are going to go. So the first nucleus which you are going to see here is the chordate nucleus. And chordate nucleus is a C-shaped nucleus. It has a head, it has a body, and it has a tail. The last part of this is dilated and forms the amygdala. Amygdala is not a part of the basal ganglia, it's part of the limbic system functionally. Next, you are seeing the subthalamus. This is lying between the thalamus and the midbrain, so this is the subthalamic nuclei. And the third one is the substantia nigra, which is present in the midbrain. And this is just to show you how the ventricular system is related with the nuclei here. Now, what we would do is that we are again looking at a sagittal section, and we are going from lateral to medial. So what you are seeing laterally is this nucleus here, which is present within the C of the chordate nucleus. So this nucleus, which is shown in green, it looks like a it's called a lentiform nucleus because it looks like a lens. So because it is biconvex type of appearance, so it looks like a lens. So it is called the lentiform nucleus. And over the top of the lentiform nucleus, you are seeing the chordate nucleus. This lentiform nucleus has two parts. The lateral part of the lentiform nucleus is putamen. The medial part of the lentiform nucleus is lobus pallidus. Okay. So functionally, striatum is chordate and putamen. Anatomically, you have a lentiform nucleus which has a lateral part which is called the putamen and a medial part which is called the lobus pallidus. So you are seeing the lentiform nucleus. So we are going from, in a sagittal section, going from lateral to medial. You see the lentiform nucleus, and over the top of the lentiform nucleus you see the chordate nucleus. Again, you are seeing here, this is the lentiform nucleus, this is the chordate nucleus, and medial to the lentiform nucleus you see these bundle of fibers which are going up. These are the fibers of the internal capsule. So you can see the fibers from the cortex are converging and they are passing between a space between the lentiform nucleus and the thalamus. This is a space which is called the internal capsule, and then they go down. Okay? Here you are seeing the arrangement again. This is the lentiform nucleus. You can see the thalamus here, and you can see the chordate nucleus. Can you make out now? So the lateral part, you have the lentiform nucleus, then you have medially the thalamus, and over the top you have the chordate nucleus. Between the lentiform and the thalamus, you would have the fibers which are going up or coming down, which are called the internal capsule. This is the lentiform nucleus. So you see the lateral part is the putamen, the medial part is the lobus pallidus, and within the lobus pallidus, this is lobus pallidus externa, this is the lobus pallidus interna. Now you can see the chordate, this is the putamen, lobus pallidus externa, interna, and the most medially is the thalamus. If we look at into the sagittal view, you would see the lentiform nucleus, the thalamus, the chordate, and in between them you can see the internal capsule passing. So this is the lentiform, chordate, thalamus, and in between them you see the fibers of the internal capsule which is passing on. Next slide, we are showing you this in a horizontal section. So this is a horizontal section. You see the chordate nucleus, the head of the chordate nucleus. Can you make out this? Yes. This is the head of chordate nucleus. The head of chordate nucleus. This is the tail of the chordate nucleus at the back. So you can make out the tail. This is the head of the chordate nucleus. This is the lens-shaped nucleus here, which is the lentiform nucleus. And within the lentiform nucleus, you have the lateral part, which is called the putamen. The medial part, which is called the lobus pallidus. And it has two parts, the lobus pallidus externa and interna. This is the thalamus. So you see the thalamus lying in the midline, the medial, and between the lentiform and the thalamus, you see the white matter bundle, which is called the internal capsule. This internal capsule has an anterior limb, a genu, and a posterior limb. The posterior limb is quite important because most of the fibers of the sensory tracts, the medial lemniscus, the spinal lemniscus, the corticospinal fibers, they are all going to pass through the posterior limb of the internal capsule. Imagine any hemorrhage or an infarct in the area near the basal ganglia would inevitably affect the internal capsule organ, resulting in contralateral spastic type of paralysis and loss of sensation of half side of the body. So you can see that it is in close proximity to the basal nuclei, and it is also in close proximity to the thalamus. So any infarct or hemorrhages which are going to affect this area are going to affect the posterior limb of the internal capsule, which is the place through which most of the fibers, either the corticospinal fibers or the medial lemniscus and the spinal lemniscus, are passing.
Okay.
Yes.
The anterior part, posterior part, and what's the part?
Genial. Yes. We will do the internal capsule next week in detail, but just for your reference at this point of time. Okay. So the next diagram which we want you to look at is that there are 4 groups of neurons here. The group A is the striatum, group B is the neurons which are called the globus pallidus, then you have the nuclei of the thalamus, and then you can see the motor nucleus in the cortex, which is the upper motor neuron. So first what you need to consider is that at rest, you see the activity of the striatum. There is no activity in the striatum. So striatum at rest is not excited, it's not sending any impulses. But if you look at the globus pallidus, you would find that it is tonically active at rest. So what it is doing, it is sending tonic inhibitory discharge to the thalamus, and as a result, thalamus cannot excite the cortex, and the cortex is not going to perform any involuntary movements. If you look at the excited state, once the cortex is going to send activation signals to the striatum, this will result in transient excitation of the striatum, which will result in a transient inhibition of the globus pallidus, which will result in activation of the thalamus and activation of the cortex. So this is the normal function of the globus, the basal ganglia.
This is the direct, right?
Yeah, this is the direct pathway. Okay, so before I start the discussion on a direct and the indirect pathway, what I need you to understand is that whenever you are going to perform a movement, you have some primary muscles which are active. So for any particular movement, you have certain primary muscles which needs to be activated. But at the same time, you want all other muscles to be inhibited. Okay? So the function of the direct pathway is to activate the prime movers, or the ones which are principal muscles which need to be activated in necessary for a movement. While at the same time, you need to inhibit all other motor activity. Because if the other motor activity is there, you would have abnormal movement. You cannot perform a movement if you have an abnormal activity which is going on besides that. So the direct pathway is there for activation of those muscle sets which are required for that particular movement. But you need the indirect pathway to, at the same time, to stop all other involuntary movements. Okay? So you need both pathways, direct pathway and indirect pathway for this function. So first we are going to look at the direct pathway, and then we are going to look at the indirect pathway. So when you are going to start a movement, there would be an excitation from the cortex going to the striatum. In terms of the direct pathway, once the striatum is going to be excited, it is going to inhibit the globus pallidus interna, and as the globus pallidus interna is going to be inhibited, the inhibitory discharge to the thalamus will decrease, and as a result, thalamus will be able to activate the cortex. So this is the direct pathway, which is easy, simple, no problems. You have excitation from the cortex, excites the striatum, striatum